Bonjour tout le monde, bonjour et bienvenue à cette sixième édition, ce sixième épisode des entrevues Code Vie. Welcome to the Code Life interviews. And in this episode, a really interesting one, we're going to be focusing on trauma care at the Montreal General Hospital's Trauma Center. Le centre de traumatologie David S. Mulder est l'un des 3 centres de traumatologie de niveau 1 pour les adultes dans la province. Il couvre un vaste territoire, on parle de la Montérégie jusqu'au Grand Nord, en passant évidemment par Montréal, et traite les patients avec les blessures les plus graves et les plus complexes. So that's more than 1,500 patients who are severely injured every year in car crashes, falls, victims of crime, also of gun violence, are treated at the MGH Trauma Center every year. So the scope of the center really extends also beyond this emergency care. It includes prevention, research, and teaching, as well as rehabilitation, all very important pieces of the puzzle. And it's really a fascinating place. And here to give us a look at what it's like inside, an inside look, nos 3 invités exceptionnels. On a le docteur Jeremy Grushka, who's a trauma surgeon, who's stepping in today for Dr. Tarek Razik. It's the ICU LiFE. So thanks for being with us. We have Claudia Diorio, who is a former patient and Code Life leader and ambassador with a really incredible story that you'll be sharing with us, so thanks for being here as well. And Melissa Donaldson, clinical nurse at the ER, to give us some of the nursing perspectives on what it's like to be part of that team. So Dr. Grushka, I want to start with you, and I want to sort of establish a little bit of the background for traumatology in Quebec, because it's a relatively new concept, new system for Quebec in any event. And it was implemented in the early 1990s by, really pioneered by Dr. Mulder, and who was leading that initiative, of course, with the MGH at the forefront. So what difference did it make at that time? What did his work change in the life of Quebecers who were severely injured?
It's a great story, really, and we're here today because we're standing on Dr. Mulder's shoulders, and really an incredible amount of work that he did and Dr. Ray Brown did back in the 90s. Trauma care in Quebec earlier was still involving the same doctors and nurses and ideas that we have today, except people were working in silos. They weren't really working in teams. And Dr. Mulder's work was really about organizing trauma care into a system where there was a set approach about how to take care of a patient from point A to B to C through a system. Prior to that, about the average mortality rates in Quebec from severe trauma was greater than 50%. And after the implementation of a trauma system, which didn't involve new training or new people, but just a way to organize the personnel that was present, that mortality rate decreased from approximately 50% to below 8%. Mm-hmm. Now imagine you had a drug that was on the market now that could take disease process X, and you can take a mortality rate from 50% to 8%. This would be the hottest drug in the world. Mm-hmm. And the work that was done about how to organize patient care, not just within a hospital, but also within the framework throughout the province, a network of receiving hospitals, referral hospitals, so level 1, 2, 3 centers, and how to organize a team to properly take care of a patient dramatically decreased mortality rates. And that's why we have the success that we have today. And it's really all thanks to the leadership and the vision and the hard work of Dr. Mulder.
Mm-hmm. And of course, things are evolving always in trauma care. I want to get your perspective on, or just a look inside what your life is like. I think people have a lot of perceptions about what your work is like based on, television series, on movies. Is there a typical day for you in trauma?
Well, yeah, typical is a fun word, and there's a huge amount of variety. So we never know what will come through the front doors, and that's a little bit of the exciting part of trauma. I think first thing to remember is that this is a 24-hour-a-day, 7-day-a-week game. It happens all the time, and often severe injuries are going to be happening when you least expect it. It's the middle of the night, it's weekends, it's holidays. So the team always has to be prepared, and the focal point of that is the team. Trauma care, I can talk about my day as a surgeon and what it's like to resuscitate a patient and be in the operating room, but none of this is done by one person. And I think where the media aspect comes in, television shows, the rest is always focusing on the doctor, and we're a cog in the wheel. The trauma team is made up of an enormous amount of highly skilled, highly trained professionals. The nurses, the pharmacists, the respiratory therapists, the préposés aux bénévolents that are helping with the patients, unit agents, all of the subspecialty services, multiple specialty areas of nursing. That entire machine is necessary to take care of one given patient. And Dr. Razik, who's not here today, but as a mentor of mine, it was always hammered in the idea that the single most important member of the trauma team is the patient, and how that patient is responding in terms of their physiology, their vital signs, that dictates what we do. So on any given day, you have an entire trauma team that's in the hospital, they're not at home, they're sitting, and we're doing our regular work, whether that's general surgery work, emergency medicine work, anesthesia work, the pager goes off, and we get alerted that there's a critically injured patient who's showing up into the emergency department. An enormous amount of resources, both physical and human, are mobilized, and we're there to take care of that patient. And that involves resuscitation in the emergency department, work with our radiology department, getting a patient up into an operating room and doing life-saving, limb-saving surgery. We bring in resources from all of the other subspecialty services, involvement of the intensive care unit, the regular hospital floors. And while this is happening, all the other work that we're doing is existing in the background as well. And it really speaks to the necessary elements of having a well-oiled machine of a team working together to save the life of one patient.
And Melissa, turning over to you, what are some of the misconceptions about your work, about the nursing work that happens? What is a shift like for you?
So it's never dull. It's always different. We never know what to expect. I would think that people don't realize how much nurses are involved in the care of a trauma patient in the emergency room. We are on the front line. We receive that phone call from the paramedics giving us information on the patient who is coming in, on the situation, the mechanism of injury, the vital signs, the mental status. Once we have all this, the nurse is also responsible to discuss with the emergency physician and decide if they will activate that trauma team. Once that decision is made, the nurse needs to make sure that everybody is aware, from the patient attendant, the clerks, the radiology staff, everybody needs to be on the same pace. Then nurses again are responsible to make sure that all the equipment is ready in the room. Regarding the situation, we have to anticipate what we will be doing and what equipment we'll be needing. So once the patient comes in, we're going to stay with this patient for 30 minutes, an hour, 2 hours, 3 hours. It depends on the situation. And once the situation is handled, then we're going to transfer the care to another unit or the surgical team if needed. But we're very, very involved on different aspects.
Yeah, and I think people might not know to what extent you are hands-on and involved, and how crucial the nurses are as part of the team.
Yeah, exactly. So we're really nurses are really essential members of the trauma team, and because we are always in the emergency. Different like the pharmacists and the trauma surgeons, they have other responsibilities, and we are always there. So we have to always be ready for what's coming.
Okay. Claudia, je vais me tourner vers vous. Plusieurs Montréalais ont entendu votre nom la première fois aux nouvelles. C'était la même chose pour moi en tant que journaliste. Puis là, maintenant, vous avez fait au cours des dernières années un grand travail de sensibilisation. Parlez-nous un petit peu de votre histoire et comment vous êtes ramassé au MGH dans le centre de traumatologie à l'hôpital général de Montréal.
Oui, certainement. Mais donc, à l'âge de 16 ans, avec mes 2 amis et plein d'autres amis, on était sortis pour une fête d'été. Et tout allait bien, on passait du bon temps. Quand c'était le temps de rentrer à la maison, on attendait un taxi quand un garçon qui habitait pas trop loin de chez nous a proposé un lift. Donc, on s'est dit, great, we're gonna save money. Alors, on a accepté le lift. Et little did we know, il était très dangereux. Il avait un comportement, je dirais, incontrôlable. Donc, il a décidé de rouler à 130 dans une zone de 30. On était à quelques minutes de la maison, peut-être 2 ou 3 minutes. et on a foncé dans un arbre. Donc, ce qui a fait en sorte que je suis tombée dans un coma directement. Mes amis qui étaient avec moi ont été grièvement blessés également. Ce qui a fait que moi, j'ai eu la chance, en fait, dans toute cette malchance-là, la chance que j'avais, qu'on avait, c'était d'être si proche de l'hôpital général, dans mon cas, où on m'a amenée. Mais malgré mon jeune âge, à cause de la sévérité de l'accident. Mm-hmm. Et j'ai été prendre en charge tout de suite. Alors, le peu de chances que j'avais de, un, survivre, et de deux, si je survivais, dans quel état j'allais revenir, est-ce que j'allais être légume ou pas, chaque seconde comptait. Donc, à partir de l'impact dans l'arbre, chaque seconde compte. Chaque seconde, je perds quelque chose. Donc, le fait que j'ai été déplacée très rapidement à l'hôpital, j'ai pu, même s'il a pris beaucoup de temps, évidemment, la réhabilitation, mais je suis capable, aujourd'hui, j'ai été capable de retrouver mes habiletés.
Dites-moi aussi, vous aviez dit que dans le processus, on parle de la différence entre la vie et la mort, d'être amené à l'hôpital général de Montréal, puis être traité très rapidement là, dans les premières minutes, mais aussi tout le processus de réhabilitation. Je veux dire, comme on vous voit aujourd'hui, c'était pas ça le prognostic là, au début. Quelle différence est-ce que l'hôpital général de Montréal a fait entre justement la survie, mais aussi je ne vais pas dire le peu de séquelles, là, mais la qualité de vie que vous avez aujourd'hui?
En fait, vu que chaque seconde compte au début, j'aurais pu, si j'avais été amenée un peu plus tard, j'aurais pu perdre beaucoup plus que j'avais perdu. Donc, moi qui ai été, par exemple, paralysée d'un côté, j'ai pu retrouver l'usage. Si on avait attendu trop longtemps, est-ce que la même lésion qui a causé ma paralysie, mon hémiparalysie, aurait pu être, comment dire, traitée à temps pour guérir du mieux qu'elle pouvait par la suite? Mm-hmm. Donc, le centre de trauma a fait toute la différence. Parce que c'est dans les premières secondes que ça compte. Après la réhabilitation, oui, ça m'a aidé énormément. Moi, je me suis réveillée, je me rappelais plus comment écrire, compter. J'oubliais tout. Je veux dire, j'étais complètement pas là. J'arrivais pas à marcher, à bouger d'un côté, même à sourire. J'arrivais plus à sourire. Donc, c'est sûr que tout ça, ensuite, j'ai pu réapprendre tranquillement, mais sans avoir été très bien prise en charge dès le départ, malgré la réhabilitation, malgré toutes les thérapies. Puis ça revient aussi à ce que le docteur disait par rapport à toute l'équipe. Donc, oui, c'est ça, c'est pas juste le patient, ou c'est pas juste le docteur en trouvant, mais c'est pas juste l'infirmière, c'est toute l'équipe qui vient avec. Donc, tous les thérapeutes après qui vont m'aider à retrouver mes capacités. Mais sans la base, là, j'aurais pas réussi à retrouver tout ça.
Okay. Puis vous avez parlé d'un docteur en particulier qui a cru en vous beaucoup, puis qui vous a beaucoup poussé aussi, là, qui faisait partie de l'équipe.
C'était mon physiatre, c'était Dr Daguerre, qui, elle, depuis ma rencontre avec elle, donc, moi, de ce que je me rappelle, c'était à l'hôpital, au centre de réhabilitation de Montréal. Elle a cru en moi, donc, un système qui est très being cautious. Ils ne veulent pas laisser le patient faire trop, aller trop vite, aller faire ci et ça. Moi qui avais une volonté de vivre et de retrouver mes capacités, grâce à elle, qui fait donc partie encore une fois de toute l'équipe, elle m'a encouragée puis elle m'a permis d'aller, à la hauteur de ma rapidité. Et ainsi retrouver et atteindre mes buts, c'est-à-dire de finir l'école et de pouvoir retrouver une vie normale, presque.
I kind of want to see Melissa and Jeremy, how you, it's very moving to listen to Claudia's story. You said you remembered Claudia, Melissa, from that night. What is it like listening to her now?
Well, it's great because we rarely have a chance to see like the outcomes or what's happening with the patient because, like I said before, once they're being taken care of by other specialists in emergency, our work is done and that's it. So it's great to see that, we can make a difference.
Mm-hmm. And for you?
I would echo the same as Melissa just said. I mean, listening to Claudia's story, it's incredible, and to see where she is today and everything that she's accomplished, it's wonderful for you and for your family. And the important thing to remember is that trauma is a human story, and it's not just patients and operations and equipment. It's human beings who have a life and a story. So the most wonderful thing is to be able to see someone come back from where they were, from that first night when you came in, and to where you are today. And despite all the work we've talked about for the team that puts into that, it's an enormous amount of work that you put into it. To do that rehabilitation, to not lose hope and to move forward is incredible. And that's why we all do this work.
And Dr. Grushka, on that topic, sometimes it can be a little bit of a sensitive subject, but how are you working to improve, and what do you need also to improve outcomes for patients? So it's more than a survival story, it's also quality of life in the end.
Yeah, that's, it's an excellent
question.
Big question. and a very good one, and an important one, and a timely one, especially as we look, moving into an election year in Quebec. One of the things that Claudia at first mentioned, number one, was that importance of time. Trauma, without question, the way that we will have a good outcome is getting patients to trauma centers in a rapid amount of time. Every single minute counts. I think that was an excellent thing to say. And there's an underestimation about how important every minute is. So first things first, we need to look at our pre-hospital system. How are we getting patients triaged? How are we getting them to trauma centers? Further development into the province of rotary wing transport, a helicopter program, where we could rapidly be bringing patients from a scene, just like the car crash that Claudia just described. You get a helicopter onto that scene, you get them to the Montreal General Hospital in 5 to 7 minutes, a rapid assessment in the emergency department, and then into an operating theater can be the difference between life and death. It also is the difference between a functional quality of life that is offering a 16-year-old child at that time the opportunity to have all of the wonderful things that someone should have from life. So definitely further developments in terms of pre-hospital triage, specifically by looking at development of rotary wing transfer services, would be enormous. The second thing that we need to look at is also as a human resource program. The trauma team, as we've described here, is made up of a lot of components. We need further investment into human resources. We need more nurses. We need more pharmacists. We need more respiratory therapists. We need to have resources to be able to provide ongoing continuing education, skill development, retention of highly skilled labor, and that comes with a significant financial investment into the medical system. New technologies in terms of what we do in the operating theater, in the ICU for traumatic brain injuries, for massive hemorrhage and resuscitation. As you know, we've started a Roboa program, which is using a catheter with a balloon that's inserted into a large blood vessel, the aorta, to arrest torso hemorrhage. And we're the center in Canada that uses this device the most, with excellent results. But that involves training and skill. And as we further want to use new modern technology, it involves a financial commitment to raise funds to develop those programs. We've just been fortunate enough to redesign our emergency room with 3 new trauma bays that are allowing us to provide state-of-the-art care. And when we look at the nature of patients who are coming into the hospital, we have complex, severely injured patients. We're able to do great work in the hospital, but there's also a significant amount of work that needs to be done after the injuries have been fixed, after they've been stabilized. Well, what happens about rehabilitation with ongoing care? Just as Claudia's story, when she met Dr. Dager, was over at the rehabilitation hospital, there needs to be further investment in those resources so that we expand the field beyond just the walls of the Montreal General Hospital, but understanding that patients are going to need further therapies as they're moving into the rehabilitation stage. So I think those would be a couple of key areas to work on as we look for a vision of how to further develop the trauma program in Quebec.
And I just want to go back very quickly to what you were talking about helicopters and the rotary component, because you're serving a huge territory. It's one thing to be in downtown Montreal, but you've had accidents on the South Shore where there's no way people are going to get to the right place in a matter of 5 minutes.
And that's a very good observation, Annie. And it's important when we're discussing about the Montreal General Hospital, we're not just talking about what's happening between Atwater and Saint-Denis. It's a very large geographic area on the island of Montreal, but also along the entire Montérégie and into the South Shore. We're receiving patients that are, badly injured down closer towards the Saint-Jean-sur-Richelieu, out in Valleyfield, large areas off the West Island. And we all know what traffic is with orange cones on the island of Montreal. The ground is not an easy way to move patients. Weather and winter, we're living a significant portion of the year under, maybe austere is a harsh word, but certainly under
I think that's correct.
climate conditions. And we know without question that you need to get patients to the hospital as quick as possible. This is not new data. This is not new science. We've known this for decades. And the ability to move patients in a quick, safe fashion with highly skilled EMTs on a helicopter from scene to hospital is essential. Mm-hmm. And that is really one of the, if not the most major resource that we need to develop within the province of Quebec to be able to continue to help patients just like Claudia. And mm-hmm. we've had patients who come in after significant delays in transfer because it takes 35 minutes to get from the South Shore to the Montreal General after a severe car crash. And patients need to go to the centers that have the capabilities, neurosurgeon, orthopedic surgeons, the entire trauma team, to be able to address these complex injuries. Patients are rarely coming in with just one injury system. There's a whole host of injuries, and you need a hospital that can take care of that patient from A to Z, and that's what the Montreal General Hospital is.
Mm-hmm. And Melissa, I want to talk a little bit about the physical improvements. Il y a eu beaucoup d'améliorations. Mm-hmm. C'est beaucoup plus clair, c'est beaucoup mieux organisé, mm-hmm. vous avez plus d'espace. C'est beaucoup, la Fondation de l'hôpital de général de Montréal a fait une grosse différence. Qu'est-ce que ça a fait comme différence pour vous d'avoir ces lieux-là qui sont beaucoup plus adaptés aux besoins d'aujourd'hui?
Mm-hmm. So first of all the improvement and the changes that were done are amazing. Like 20 years ago, we were getting the patient in a trauma room that looked a bit like a garage. Now it's we are lucky enough to have like 3 individual rooms, so we can navigate through these rooms at the same time. Ça a beaucoup amélioré notre qualité au niveau du travail. Toutes les salles sont équipées de la même façon avec la technologie de pointe, mais surtout, ça a aussi donné beaucoup d'avantages pour le patient parce que là, il y a premièrement, tout est privé, l'intimité du patient. Ça nous permet de travailler plus rapidement. Puis, for sure, better outcomes just because of that. So it's amazing what they did.
Puis de votre point de vue, avec votre perspective, c'est quoi les améliorations when we're talking about outcomes? What's necessary in your mind? Pour un petit peu compléter ce que le docteur Crochot
Yeah, well, from a nursing point of view, I think to be better, we have to be prepared. So a bit the same, like continuous education, practice. At the MUHC, ça a toujours été encouragé de poursuivre dans la formation, de permettre aux infirmières d'assister à des conférences scientifiques avec comme sujet la traumatologie, de suivre des cours spécifiques au trauma nursing. So everything, all of this, they're going to have better skills, they're going to be more equipped, more confident, and I think that's going to be resulted in better outcomes.
OK. Puis, Claudia, je veux revenir à vous. Vous êtes maintenant ambassadrice. On parlait de leader code vie avec d'autres jeunes professionnels comme vous qui s'impliquent pour soutenir les soins vitaux à l'hôpital général de Montréal. Ça ressemble à quoi pour vous aujourd'hui cette implication-là, puis ce travail de prévention-là?
Mais c'est surtout, je veux dire, dans la vie de tous les jours, d'en parler. Évidemment, de participer aux événements, d'aider la Fondation littéralement à faire des appels, d'appeler, de partager mon histoire, mais de sensibiliser énormément les gens sur l'importance de... Parce que j'ai l'impression que beaucoup de personnes pensent que le système de santé public, we need to give, c'est déjà fait. Non, c'est faux. En donnant, on aide énormément le système à s'améliorer, on lui donne une marge de plus. Parce que l'argent, il n'y en a comme jamais assez. Et pour un centre comme le nôtre, qui permet justement de sauver des vies à combien de kilomètres à la ronde, puis où on retrouve vraiment des spécialistes de fine pointe, c'est en donnant qu'on arrive vraiment à constamment s'améliorer, puis arriver à être dans les meilleurs au pays. Pourquoi? Pour sauver le plus de vies. Pas juste pour être les meilleurs, mais en termes de pour sauver le plus de vies, pour faire en sorte que justement, quand on voit l'augmentation des violences, quand on voit l'augmentation du nombre de jeunes ou moins jeunes qui se rendent au centre de trauma, bien, on a les moyens de s'en occuper. Puis les personnes sont mieux formées, on a des meilleurs équipements. Hélicoptère un jour, parce que mon accident, s'il était arrivé, on l'a dit plusieurs fois, mais je remets l'accent là-dessus, je ne serais pas ici aujourd'hui. C'était arrivé, c'était pas à Ville-Montréal.
Dr. Grushka, Claudia just touched earlier on the different, on people who will come to the center, victims of crime. Have you seen an evolution in the type of injury that you're treating? Who's coming in, and how is that evolving, and how are the needs evolving consequently?
Yeah, we're certainly seeing an increase in the number of trauma patients that are coming in annually, and also an increase in the severity of those injuries. Most notably in a couple of areas. Number one, we're certainly seeing more and more penetrating trauma. Anytime we listen to the news on any given night, we hear about shootings and stabbings across the island of Montreal and up on either of the shores. And that is something that is absolutely true and present. In the past, 10 years ago, we were always talking about knife and gun clubs on the weekend, but now you're just as lucky, or you're just as likely to being able to see a patient come in who's shot or stabbed on a Tuesday afternoon as you will on a Thursday night. These are complex and severe patients. The issues with gun violence are very real. We think we're often protected from that here in a safe city of Montreal and throughout Canada, but that's not true. And the volume of penetrating trauma and the severity of injury secondary to gun violence and to stabbings as well is growing exponentially. And it brings in the question of augmenting resources in the hospital, but also the importance of injury prevention, of rational gun laws, and social advocacy in order to decrease this public health problem. The second area where certainly we're seeing an increase is in injury in our elderly population, specifically from falls. Thankfully, people are living longer, healthy, happy, productive lives. But there are realities that come through as we get older, and falls at home, falls out in society are happening in an elderly population that's often on other medications that can impact their care, specifically blood thinners. And they're presenting quite ill, quite severely injured, and that has a significant impact not only on what's happening in the hospital, but also happens within their home. Individuals who can't go back to their homes afterwards, which puts a strong burden on the public health system. So we're seeing a evolving population in trauma patients that are sicker, more complex, and with the byproduct of specific social determinants of health. Another important thing to note is we're also fortunate enough to be a receiving center for our partners through Nunavik and through the James Bay territories. And it's a privilege to be able to provide trauma care to the Indigenous populations in Quebec. And certainly our volume of injured patients in those areas is also steadily increasing. And it brings in, again, the concept of how do you rapidly transfer a patient from Kuujjuaq to Montreal. And that presents specific logistic issues and how to properly implement programs such as telemedicine to be able to liaise with our partners in those areas. So there's a lot of new challenges in trauma care that we weren't faced with 20 years ago when we were first designing the trauma system in Quebec.
And you know, you already have prevention programs that are in place, but do you see that taking an even greater role in the coming years when you're addressing falls, when you're talking to young people? What role do you see that playing?
Absolutely. Injury prevention and an injury prevention program is it's a cornerstone of any mature trauma program. The best way to avoid any of this is to prevent someone from getting injured. I think the Montreal General Hospital, through our injury prevention program, has a large number of community outreach programs, from safe rational helmet use for cyclists to fall prevention for geriatric patients at home. We run a Stop the Bleed course to teach individuals how to use tourniquets, and that goes from kids in kindergarten all the way up to very senior adults. What to do when someone's bleeding, how do you put a tourniquet on properly. I think a strong investment in injury prevention is essential in order to try to decrease the burden of injury that we see in the hospital. And a logical extension of that, besides just education that's happening in schools and community outreach programs, is applying some political pressure to have our governments take injury, and certainly injury secondary to violence, whether that's firearms, stabbing, gender-based violence, to make these political items that are discussed, that are debated, and that are then legislated in a way that we come up with rational ways to decrease that trauma burden. And it's an enormous amount of work of what's done through the trauma program at the Montreal General Hospital to push forward those injury prevention programs. And we've just touched the tip of the iceberg. Mm-hmm. I can easily see in the next 5 to 10 years that those programs really taking on a much more substantial and developed role.
And before we take some questions from people who are joining us, I wanted to ask you a little bit about the Center for Global Surgery that is doing some incredibly important work right now, as many of you probably know, in Ukraine, or helping teams. We're not even talking about doctors and nurses anymore. We're talking about people who are on the front lines, paramedics, and probably beyond, to save lives there. How have you been implicated in that? Maybe to Melissa as well, and what's that meant to you?
Yeah, the Center for Global Surgery is a wonderful add-on to our trauma program, and it's under the leadership of Dr. Razek and Dr. Deckelbaum, who have really built this up into a world-class program over the past few years. Our current work is really focused on capacity building and education. And Dr. Deckelbaum designed a trauma team and disaster course a few years ago that really focused upon how do all the members of a trauma team work together. And we've worked it now in over 20 countries around the world. I've been to Ukraine twice before in teaching this course that Dr. Deckelbaum developed. And the need is enormous across the world, and what's happening right now in Ukraine is an absolute tragedy. And it's been a privilege to be able to work with our partners there to design trauma team education resources where there's a series of videos that go over life-saving procedures such as insertion of a chest tube for a pneumothorax, how to perform hemorrhage control, how to perform a trauma laparotomy, and how to work together as a team with the doctors, nurses, community workers, therapists that are present. We've had those videos translated into Ukrainian. They've been disseminated at various hospitals and health outposts across the country. And being able to just play a small role of support towards the healthcare teams in Ukraine has been an absolute privilege. And it's horrific to think of what they're going through. But the impact to be able to help care for injured patients across the world is something that's incredible, and it's a core component of the mission of the Center for Global Surgery. And we're still working on that now and to further redefine these programs, these videos, and these educational resources in order to augment capacity to help with the care of innocent injured patients in the middle of a war.
Mm-hmm. And I want to move to some questions that we have. And this is probably something that you get a lot. Melissa, je vais la diriger vers vous en premier. Comment est-ce que vous faites pour... how do you cope? Comment est-ce que vous différenciez vie professionnelle, vie personnelle? Comment passer à travers ce que vous voyez, les situations difficiles que vous pouvez voir au travail?
Mm-hmm. Mais en fait, on n'est pas ceux qui voient le pire. Je pense que le pire, c'est tous ceux qui travaillent dans le préhospitalier, qui arrivent directement sur les lieux d'un trauma, d'un accident, d'un crime. C'est sûr qu'on voit des choses difficiles à tous les jours. Pour coper, c'est un peu...
For lack of a better word, yeah.
Oui, c'est pour... je pense que ce qui est important, c'est de se rappeler que c'est notre travail. Donc, on est formé pour ça. On a des outils et des habiletés pour répondre à des situations puis pour faire face à certaines choses, comme n'importe quel autre professionnel dans n'importe quel domaine qui peut voir des choses difficiles ou vivre des moments de crise. Ça reste qu'on est des professionnels, on est entraînés pour ça. Donc, c'est probablement plus, pas facile, mais on s'attend à des situations comme ça. Quand c'est plus difficile, c'est certain qu'à travers notre équipe, comme disait Dr. Grushka, on a beaucoup de communication, on essaie de faire des séances de debriefing à l'intérieur du travail. Puis, pour ce qui est de la vie personnelle, mais je pense que tout le monde peut trouver la façon de balancer là, les deux aspects qui peuvent être plus difficiles ou troublants. Mais à l'hôpital, dans le milieu de travail, on essaie de participer à des séances qu'on appelle debriefing pour pouvoir justement verbaliser un peu sur des situations plus difficiles.
And for you, Dr. Grushka, how do you cope?
Yeah, well, it's there's no easy answer for it. I think it was quite nicely answered by Melissa. We are trained professionals, and part of that training is to learn how to compartmentalize those feelings. But it's important to remember that at the end of the day, again, trauma is a human story, and we're all human beings. And some of the horrific things that we see impacts us at a human level. I think the number one thing to remember is to take a moment to try to digest what happens. It can be a horrific moment where, you know, a young 22-year-old comes in after multiple stab wounds. They're in our resuscitation bay. We operate on them in the resuscitation bay, opening up their chest, opening their heart, trying to control bleeding, and they die. And then there's all the background noise, the things you need to run to do and take care of other patients. You have to take a moment, one, to digest what has occurred, and as Melissa said quite well, talk about it with your colleagues. We do simulation training, and I have to say it's one of the few places in the world I've worked that does that together with the doctors, nurses, respiratory therapists, pharmacists, all together. We try not to work in our individual silo. We do these training sessions together, and when something happens that is difficult, we know it's difficult for everyone in the team, and we debrief that together. We talk about what happened, what could we do better, what could we do differently, but also talking about how that's impacting us as people. And then afterwards, when outside of the hospital, it's important to involve those people in your lives that you care about into what happens during your everyday process. And you talk about it, and you talk about your feelings, and you keep going forward, always moving on to the next thing, because one reality which is always there is there's never a shortage of trauma patients. And it's happened to both Melissa and I, where there's something that impacts us quite severely, but then the trauma pager goes off. That blue light in the resuscitation bay goes off again, and now all of a sudden 2-3 more patients are coming in. And you have to be able to take a breath and regroup and move forward. And then when the dust finally settles, you talk about it with the people you're working with. And I can't think of a better group of people that I've ever worked with than the members of the trauma team at the Montreal General Hospital. And they've picked me up off the floor more times than I can remember when I'm feeling low, because it's heavy with what we see. It's an amazing group of people that I go to work with every day. And that's really what gets me through it when the waters are rough.
You're really doing amazing work as well. And Claudia, je veux juste revenir à vous. C'est quoi l'impact que vous espérez avoir sur les jeunes quand vous leur parlez? Qu'est-ce que vous leur dites? Puis, vous m'aviez dit que ça fait vraiment une différence de pouvoir vous entendre et de vous voir en personne.
Oui, exact. En fait, moi, plus le temps avance, moi, je suis jeune, mais quand même, je garde une certaine jeunesse qui fait en sorte que quand habituellement, je vais dans plusieurs écoles m'adresser aux jeunes. Avec la pandémie, ça a été un peu mis sur pause, mais j'espère que ça va reprendre bientôt pour partager mon histoire. Donc, je m'adresse à des jeunes allant de primaire au cégep université pour leur dire, écoutez, moi aussi, j'aime sortir, j'aime avoir du plaisir, j'aime m'amuser avec mes amis, mais je sais qu'on a tendance dans ces moments-là à faire des mauvaises décisions. Puis là, c'est l'alcool. Moi, je m'adresse particulièrement pour l'alcool au volant. Ça touche à tout. Ça peut être de prendre la drogue, ça peut être d'essayer de... Ah, tiens, je sais pas, aujourd'hui avec les armes, les couteaux, d'essayer des trucs avec... tout ce genre de situations-là où on n'est pas à l'abri du danger. Quand on se sent dans des situations de plaisir, des fois, à côté, il faut toujours garder les yeux ouverts sur ce qui peut être dangereux, toujours rester raisonnable. Donc, oui, s'amuser, oui, profiter, avoir du fun, sortir, découvrir, être curieux, essayer des choses, c'est bien. Il faut le faire. À un jeune âge, c'est normal de le faire. Mm-hmm. Mais pour continuer le plaisir, il faut rentrer en sécurité.
Mm-hmm. C'est ça votre message aussi au public. Qu'est-ce que vous dites quand vous embarquez? J'ai trouvé ça surprenant aussi que c'est vous qui appelez pour solliciter des dons.
Entre autres, oui.
Ça doit être surprenant pour la personne au bout de la ligne.
Ils sont heureux parce que, bon, il y a plusieurs se cherchent des activités. Donc, lorsque je l'approche, je dis oui, moi, je fais ça bénévolement, ça me fait plaisir. Je peux venir rencontrer une classe ou deux ou tout niveau, peu importe, puis m'adresser à eux. Moi, ce que j'aime, c'est casser la glace. Donc, dire OK, allô tout le monde, bon, je m'appelle Claire Zazorio. Qui ici a déjà conduit après avoir bu ou qui a embarqué avec quelqu'un qui avait conduit après avoir bu ou consommé de l'alcool? Quelques mains se lèvent, gênées. Moi, je lève la main en premier. Je dis OK. Donc là, on va parler. Puis je dis OK, donc, ceux qui ont osé lever la main, parce que je sais qu'il y en a qui n'ont pas osé, est-ce que vous êtes senti confortable dans cette situation-là? Est-ce que vous réalisez la chance que vous avez? Les réponses, on doute, oui, on réalise qu'on a pris une chance, puis on réalise que ça aurait pu très mal virer. Je dis, OK, donc comment se sortir, comment développer des trucs? Parce que le but, c'est pas de dire, OK, sortez plus, rentrez à telle heure, prenez... Non, c'est de dire, OK, donnez-vous un plan. Mm-hmm. Comment on rentre à la maison, comment on évite, encore une fois, là, je parle de tout ce qui est alcool au volant. Mm-hmm. Ça peut être n'importe quoi d'autre. Comment on planifie à l'avance, tout en ayant du fun, mais pas dépasser certaines lignes. Mm-hmm. Pour qu'ensuite, on puisse ressortir le jour d'après.
And so much of that is that's such a big part of the formula. And Melissa, you were saying that, again, I'm coming back to you saying that you remembered Claudia. I guess it was just in sitting next to her that night. I'm imagining you never would have thought when that call came in and the girls that she was with came in that she would be sitting here expressing herself like this. And yeah.
Never. It's wonderful.
Well, thanks to you and all the work you're doing. I mean, and we're talking about it earlier, is that the people who suffered the most at the moment of the accident was our families, right? I mean, when you don't know how your daughter is going to turn out to be, you don't know if she's going to be alive or dead, if you don't know, if she's going to be able to survive or not.
Well, I'm sure the family feels very fortunate. Your dad, who I've met several times, for the great work that's being done. And I want to thank you all for sharing your perspectives with us and letting us know more about the important work that's being done. And, the type of work that sometimes, because it's emergency, it's critical care, it's maybe more difficult, or there's a belief that it's more difficult to plan for, sometimes maybe not getting all of the funding that it deserves or the attention that it deserves, but clearly what you do has a huge impact and ripples really through the entire healthcare system. So thank you all for sharing your perspectives. And if you wish to contribute to preventing trauma cases and improving outcomes for patients, you can make a donation to the Montreal General Hospital Foundation through its website, codelife.ca. And I want to thank you for watching and for joining us today. Thank you, and we'll see you soon.